So now we will talk about reproductive medicine. Infertility. Definition of infertility. It's defined as failure to conceive after 12 months of regular intercourse in women younger than 35 years of age, after 6 months in women of 35 years and older. The large majority, 80–90% of couples will conceive within the first year of attempted conception, but the probability of achieving a pregnancy after the first attempt is between 15 and 20%. This means that not all women's ovulation become a baby. This is very important because during the counseling discussion with the patient about probability, should explain that pregnancy is not one shot, and not all of the ovulations become a pregnancy, but only a small part of the ovulations become a baby. Prevalence. Infertility is a disease, and its prevalence is increasing. It's very important to remember is that prevalence of infertility is age-related. So, women of 40–44 years have a 30% presence of infertility. Women between 35 and 39 have 25%, and women between 15 and 34 have a quite low prevalence of 7.3–9.1%. In Italy, infertility is a very important social disease, and in 2013 around more than 60,000 people were treated for it, which is quite a dramatic number. The causes are many. You can have the classic causes such as tubal infertility, 9.8%, and male factor, 17.9%. The main indication for in vitro infertility represent only the 30% of total cases. Then we have diminished ovarian reserve cause is increasing in prevalence. This term refers to ovulation disorders, especially due to the fact that women are at the end of their fertility period. Then we can have endometriosis in 10.2% of cases, PCOS 10% of cases in the severe form, and around 10% of patients will have unexplained infertility. So let's repeat. We have a male factor, which is 17.9%. We have tubal infertility, 9.8%, diminished ovarian reserve, then like around 9%, endometriosis 10%, PCOS 10.7%, and around 10% have unexplained infertility. Infertility assessment is performed at the beginning of couple counseling. We have evaluation of both partners. So we take reproductive history and physical examination, menstrual history to assess ovulatory function. So we see a thyroid function, prolactin levels, and LH and progesterone levels. The ovarian reserve test is fundamental since it's one of the most important prognostic factors, together with age. At the day 3 of the cycle, follicular phase, we measure the FSH, serum FSH, estradiol, and AMH levels. And then we have also semen analysis to assess male factors. In selected couples, the following additional tests may be warranted, like hysterosalpingography or 3D ultrasound scan to assess tubal patency and the uterine cavity. laparoscopy to identify endometriosis and or other pelvic pathologies, pelvic ultrasound to assess uterine myomas and ovarian cysts. So the assessment should consider ovulation plus semen sample plus anatomy. It's not only important to evaluate if the patient is ovulating or not, although many information can be obtained by evaluating the follicular and luteal phases. Anyway, um, the follicular phase in the menstrual cycle begins with the onset of menses and ends on the day before the LH surge. The luteal phase begins on the day of the LH surge and ends at the onset of the next menses. Also important to check for the prognostic factors of female infertility, which are age and ovarian reserve, which are the most important, and concomitant disorders such as endometriosis, history of pelvic inflammatory disease, hormonal disorders, prolactin and TSH, and autoimmune diseases. Age and ovarian reserve. The optimal fertility ends at 30 years of age, after which the ovarian reserve starts to decrease. If a woman gets pregnant around 50 years of age, she surely didn't use her eggs, but utilized the eggs coming from women donors of 20-30 years of age. What changes with age? The main cause of age-related decline in female fertility is poor oocyte quality rather than implantation failure. Infertility is almost always related to aneuploidy, so a wrong chromosomal asset, and not to implantation failure or endometrial diseases. So it's related to the quality of the oocyte. For this reason, the egg donation is the top reproductive model. There are old women or women with premature ovarian failure who obtain a donor egg, oocytes of good quality, and they get pregnant easily, with a pregnancy rate of more than 60% per cycle, while when a woman is 40, the probability of pregnancy is only 10% per cycle. There is a drop of live birth per transfer at 43 years of age, and at 45 years it's almost zero. So at this age, IVF is not a possibility anymore. But in order to get pregnant, a 40 years old woman will have to undergo egg donation. Ovarian reserve is a unique marker of prognosis, and there are sensitive markers for it, such as antral follicle count with ultrasound, where the doctor counts follicles ranging from 2 to 5 millimeters in order to establish the ovarian reserve. Of course, the more oocytes a woman has, the higher the probability is to get pregnant. And also FSH, LH, prolactin, TSH, estradiol, and anti-Mullerian hormone, AMH, produced only by the granulosa cells, and inhibin B. So, the ovarian reserve is measured by the antral follicle count with ultrasound and with measurement of these hormones, in particular anti-Mullerian hormone, which is produced only by granulosa cells. And these tests are performed on day 2-4, on the second or fourth day of the menstrual cycle. So according to these markers, we can divide patients into, according to ovarian reserve, into polycystic ovary syndrome, PCOS, that is patients that have ovaries in which there are more than 25 follicles, cysts, and AMH, anti-Mullerian hormone, is more than 4.5 nanograms per milliliter, and also normal responder and poor responder. So, poor responder means count less than 5 follicles, and anti-Mullerian hormone levels of less than 1.1 nanograms per milliliter. So we have these three categories: polycystic ovary syndrome, normal responder, and poor responder. It's a very important test. When a couple asks to the physician the probability to have a baby, the doctor should explain that it depends on the age and on the ovarian reserve, which are parameters that cannot be changed. Treatment. We can have assisted reproductive medicine. We can use intrauterine insemination. The oocyte will be fertilized in the body of the woman. Although there are other techniques, in Italy only intrauterine insemination is performed. It's a procedure in which processed and concentrated motile sperm is placed directly into the uterine cavity. It's the first approach that is proposed to our patients. The indications are an age less than 35 years, anatomical indications like monolateral self-injectomy, mild male factor, idiopathic infertility, and psychological indications like severe sexual dysfunction. The prognostic factors are number of cycles, ovarian stimulation, especially female age and semen quality. So let's repeat the indications. Age less than 35 years, anatomical indications like monolateral self-injectomy, mild male factor, idiopathic infertility, and psychological indications. How do we prepare our patients? There is a mild ovulation induction with the aim to obtain more than one follicle but not too many. Low FSH dose is injected intramuscularly and the doctor tries to identify the day of ovulation. In that same day, we ask the partner to produce the semen sample, which is prepared and the motile sperm is placed directly into the uterus. It's a very easy procedure and is performed in the office. And it's even a little better than in vivo conception because we can increase the ovulation rate with some drugs. We can increase the potential fertility of the semen sample with lab preparation. Although this method has disadvantages, it can be proposed as the first level test only to young women. Because if a woman is above 40 years of age, the chances to get pregnant become very low, also due to decreased number of follicles available. Side effects of intrauterine insemination are: since we cannot control the fertilization, a side effect is the multiparity, with many children. Side effect because an increased number of children is associated to prematurity, obstetric complications, and so on. Then we have in vitro fertilization, which is the FIVET. The oocyte is fertilized in the lab and then the embryo is transferred directly in the uterus of the female. There are two techniques used in the lab. We have IVF-ET, in vitro fertilization, and the embryo transfer, which is one spermatozoon in the pool succeeds in fertilizing the oocyte. And we have in ICSI, intracytoplasmic sperm injection. The doctor selects the best spermatozoa according to morphological parameters, and they are directly injected into the oocyte. Both techniques are extracorporeal fertilizations, but the first technique, the in vitro fertilization and embryo transfer, in this technique there is a natural conception, while in the second there is a manual conception external of the body due to the fact that there is a previous selection of the proper spermatozoa. So, which are the steps of this technique? You have a multifollicular ovarian stimulation in order to collect as many as possible oocytes, and we do this with FSH injections. Then we have a pickup oocyte, that is an oocyte retrieval performed with a vaginal ultrasound. The aspiration from both ovaries takes less than 5 minutes. And we have oocytes assessment by an embryologist team. and information is given about the maturity of the oocyte, the possibility to fertilize it. Oocytes in metaphase 2 are releasable for fertilization. Then of endovenous oocyte vitrification, that is performed if there are many oocytes. Then we do the semen preparation, then we do this FIVET, that is the in vitro fertilization, then we do the embryo transfer, that is the embryo produced is transferred to the uterus, and then we do the luteal phase supplementation, that is, we give progesterone. During the first phase, every 2 days, ultrasounds are performed in order to check the ovarian response, if it is adequate or if it's high or low. The aim of the doctor is to rescue a lot of follicles, because the higher the number of follicles, the higher the probability to have a clinical pregnancy at the end. In order to have a baby, more than 10 oocytes are needed. So, more than 10 oocytes. To produce more follicles, we need FSH with a dose higher than that of intrauterine insemination. FSH is given with a strict ultrasound control every 2 days, until the day in which human HCG is given to induce ovulation. There are different protocols, but every one of them needs the suppression of LH peak, otherwise the oocytes pickup cannot be planned. The oocyte retrieval is performed with a transvaginal ultrasound. With a fine needle we enter the abdominal cavity and then the ovary, and in each single follicle we aspirate the cumulus ovorus complex. The total process takes only 5 minutes, as said. Then we send the oocytes to the lab, that will send us back the information about the maturity of the egg, because, as said, only mature oocytes in metaphase 2 are eligible for fertilization. Prognostic elements. Which are the prognostic elements? They are semen quality, oocyte quality, woman age, clinics, that is, previous cycles and pathologies. As said, woman age is the main prognostic factor. Possibility to perform the embryo transfer usually happens in 75% of the total samples. In women aged more than 40 years, the embryo transfer is performed in 65% of the cases, but it will implant only in 5% of women properly. Embryo transfer is an easy procedure. The embryo is placed in a catheter, and with transabdominal ultrasound, the doctor checks the release in the endometrial cavity. And the catheter tip is placed at least 5 centimeters from the external orifice of the uterus, or at least 5 millimeters from the fundus. Then the patient starts with luteal phase support done with progesterone, said like in the natural cycle, whereas in the first part we have estradiol, and in the second we have progesterone. Progesterone can be administered in different ways, such as vaginal, preferred one, intramuscular, oral, or subcutaneous. Which are the complications of this in vitro fertilization and embryo transfer technique? We can have multiple gestation and ovarian hyperstimulation syndrome. Multiple gestations is associated with increased rates of perinatal mortality and morbidity. So single embryo transfer reduces the risk to have multiple gestations. It's important also, ovarian hyperstimulation syndrome is a complication of IVF due to high doses of FSH used in order to collect more oocytes. It's Ovarian hyperstimulation syndrome refers to a combination of ovarian enlargement due to multiple ovarian cysts and an acute fluid shift out of the intravascular space. It's due to an exaggerated response to gonadotropin stimulation. It's typical of the luteal phase or the early pregnancy, for 10 days after human choriano gonadotropin administration. If pregnancy occurs, symptoms of ovarian hyperstimulation syndrome may worsen and last several days to weeks, 6-8 weeks, since it's maintained by ECG, both that administered and that of early pregnancy. It is a potentially less threatening complication of ovulation induction. So, ovarian hyperstimulation syndrome is due to exaggerated response to gonadotropin stimulation, typical of luteal phase or the early pregnancy, and it's maintained by ECG, and it's a potentially life-threatening complication. Pathogenesis of this syndrome is due to increased capillary permeability triggered by excessive release of one or more vasoactive substances secreted during maturation and luteinization of multiple follicles. The vascular endothelial growth factor of follicular origin is the main, although possibly not the only, component responsible for development of ovarian hyperstimulation syndrome. In fact, VEGF is a potent promoter of neovasculogenesis. It may increase permeability of blood vessel walls, mediated in part by nitric oxide, thereby disrupting functional integrity of the vascular bed and the balance of corporal fluids. It can induce changes in cellular actin fibers, which may compromise the integrity of tight cell junctions. Treatment. We have a primary prevention done with GnRH agonists like triptorelin, and it induces a spontaneous LH surge to trigger ovulation. But it's an antagonist of VEGF and will reduce the risk of ovarian hyperstimulation syndrome to less than 0.5% of incidence. And primary prevention is done also through close monitoring. In case of mild ovarian hyperstimulation syndrome, we just do observation. In case of moderate syndrome, we do observation, bed rest, provision of adequate fluids, sonographic monitoring of cyst size, and also evaluation of serum electrolytes, hematocrit, and creatinine. In case of severe syndrome, we maintain high blood volume while correcting the disturbed fluid and electrolyte balance. We relieve secondary complications of ascites and hydrothorax, and we prevent thromboembolic phenomena. Okay. There is a new law that states that no more than 3 embryos were allowed, and so on. Vitrification is performed today for oocyte cryopreservation. We have oocyte cryopreservation, which is egg freezing. It's a rapidly advancing breakthrough technology in which a woman's egg oocytes are extracted, frozen, and stored in an oocyte bank. We can have social freezing in case of desperate housewives, oncofertility, or oncofertility that women will have to undergo CT. And we can also have cryopreservation of supranumeral retrieved oocytes to increase the cumulative chances of success per cycle of stimulation. Can have also embryoblasto vitrification, an exception to the general prohibition of cryopreservation. Any surplus embryo may be cryopreserved if their transfer is contrary to the needs of procreation or the interest of the patient's health. Okay, now we can also perform pre-implantation genetic screening to increase term pregnancy rate, to evaluate aneuploidy after blastocyst biopsy. The indications are age, recurrent implantation failure, recurrent miscarriages. The limits are polyploidy, uniparental disomy, point mutations, duplications, deletions. The pre-implantation genetic diagnosis, not screening, in this case in couples where one of the partners has genetic or chromosomal abnormalities. So to reduce or avoid risk of transmitting a genetic abnormality and evaluation of single gene transfer of single gene defect after blastocyst biopsy. Okay.